talk about the Terlipressin and the management of hepatorenal syndrome, very timely topic. Let's welcome Dr. Saab.
Well, good morning, everybody. I want to first thank the organizer for allowing me to speak today on this very important topic. The essence is, what are the new concepts in acute kidney injury that are practical, that are necessary and important for the practicing gastroenterologists in the community? Here's my relevant disclosures. I'm on the consultant and speaker bureau for Mallinckrodt, who makes Terlipressin. So in the next 25, 30 minutes, we want to cover three very important objectives. We want to first talk about diagnosis and management of acute kidney injury. And as our previous speaker said, not all AKI is HRS. HRS is a diagnosis of exclusion. You know, like for hepatitis B, we have surface antigens that are diagnostic. For hepatitis C, we have antibodies and viral levels. For HRS and fatty liver, they're diagnosed with exclusion. So that provides some challenges to us. And we're going to talk about, lastly, the current guidelines and recommendations and how to approach someone who has potential AKI and HRS. So this is a paper that was published a number of years ago, and it highlights that AKI, at least in our patients who are hospitalized with cirrhosis, it's not uncommon. Roughly 1 out of 5 people who are hospitalized with cirrhosis have AKI. And you can put the cause of AKI into 3 major buckets: pre-renal, renal, and post-renal. And over 2/3 of individuals who have AKI with cirrhosis and are hospitalized, over 2/3 have a pre-renal cause. And you see the differential. These could be voluntary responsive, which accounts for the majority of pre-renal, the majority of AKI, voluntary responsive. People have been over diuresis. People who have infections. People taking certain medication that cause vasodilation. And a subset of individuals are not voluntary responsive. A subset would fill the category of HRS, hepatorenal syndrome. And that's our focus today, is HRS type 1. But as a previous speaker said, the majority of patients will be voluntary responsive. So this is from a guideline that was published for years ago, but this concept has resonated for a number of years. And the issue is to be able to diagnose kidney injury early on, because it becomes a slippery slope. Once kidney injury occurs, it can be very progressive to the point that it's no longer manageable with fluids or albumin. So we have some definitions now, and they're very, very granular. The AKI stage 1 means you have a change of creatinine of 0.3, which isn't a whole lot. But does that define HRS? No. 0.3 means you have stage 1 AKI, but you need to intervene. Now, one of the challenges for us is a lot of these definitions have been evolved, centered around hospitalized patients. In the outpatient, I think we need a new guideline, because we take care of a lot of people's cirrhosis, and it's very difficult for us, as an outpatient, when someone's not physically in clinic, to define AKI, to make interventions and manage individuals. Stage 2 means you have a doubling. You have a doubling of the creatinine. And it can be something as simple as 0.6 to 1.8 serum creatinine levels. And in stage 3 means you have a 3-fold serum creatinine level. These are very, very small changes, but carry a very large impact. So keep that in mind. So diagnose HRS, there's a set of criteria. Again, right now we don't have validated serum or urine biomarkers that define HRS. There are a lot in development, but nothing's been validated so far. So to make a diagnosis of HRS, first you have to have cirrhosis. Not just cirrhosis, but cirrhosis with ascites. signs of liver failure. And then I was mentioned before, you have to be non-volume responsive to out for 2 days. Can have shock, because as you know, shock could also cause AKI and kidney problems. And you cannot have taken recent nephrotoxic drugs. You shouldn't have had a recent CAT scan where they give you contrast, or taking aminoglycoside for an infection, or taking back non-steroidals, Advil, Aleve for back pain. So all those could cause kidney damage. And no signs of structural kidney injury by proteinuria. We had a patient in our ICU not too long ago, a patient who had a cirrhosis ascites, then had a rising creatinine level. But this patient ended up having proteinuria nephrotic syndrome and not HRS. We have some old definitions of HRS on the left-hand side of the slide. HRS type 1, type 2, and some new definitions that kind of mirror better the pathophysiology. This is from a nice review article published this year in the New England Journal of Medicine by Dr. Nadimi at USC, and Dr. Garcia, who's a world authority on kidney failure. And basically when it goes through this flow, the hepatorenal syndrome occurs in context of cirrhosis and portal hypertension. When you have cirrhosis, blood has a hard time going to a liver. And so you get portal hypertension. So, and your vessels get dilated. So the blood volume your body sees in these vessels is decreased. So you have a decreased effective blood volume. What does the body do? It tries to recompensate, tries to increase effective blood volume by squeezing the vessels. And if this goes unchecked and progresses, it starts affecting vessels, not just in the splenic area, but in the kidneys. So the vessels in the kidneys are squeezed. So you start getting a functional decrease in kidney function. Now, I was mentioned earlier, people when they have cirrhosis, and we assess severity of the liver disease by the MELD score. And something that's not been mentioned earlier is we keep on going through different versions of MELD score. We have MELD sodium. Before they had MELD. And coming this year, we're gonna have MELD 3.0, where we account for gender, because women are now well treated by the MELD score, because their serum creatinine tends to be lower than men. So people are listening for transplantation. And historically, if you had kidney failure, early on, you were eligible for both the liver and a kidney. Well, what happened is a lot of livers took the kidneys away from people waiting for a kidney transplant alone. So many centers have adopted policy. And they said, listen, if you're on dialysis for over 4 weeks, your kidney function is not likely to return. And those individuals that get a liver and a kidney transplantation. That was based on studies like this, that's showing that over time, hepatorenal syndrome is not just a functional problem. It causes structural damage to the kidney that becomes irreversible. So a biological reason why wait 4 weeks before considering a combined liver kidney transplantation. We've known for a long time that hepatorenal syndrome is not a good thing. Without dialysis, without intervention, the mortality rate is almost 100% at 2 to 4 weeks without any intervention. So we know hepatorenal syndrome is not a good thing. It increases mortality. It increases dependency on dialysis. Now, and as you, as GI doctors, know how difficult it is to take care of a patient with cirrhosis and ascites liver failure. Throw in that mix dialysis. It's horrible. Patients are sick as it is. They have muscle wasting, sarcopenia. They have ascites. And now they're in dialysis 3 times a week. It's purgatory. People have kidney failure, have increased hospitalizations. They keep on coming to the hospital. They're very sick and horrible quality of life. And kidney function before liver transplantation can predict kidney function after transplantation. The worse your kidneys are before transplantation, the worse it's going to be after liver transplantation. And so a lot of centers have developed strategies to minimize calcium inhibitors because they also cause kidney problems. Florence Wong published this paper, Liver Transplantation, 2015, and it's a great paper because what it highlights is one of the most common precipitates of hepatorenal syndrome. I don't know about you, but when I was in training 20, 25 years ago, they blame us. It's all our fault. Over-diuresis, aggressive Lasix and adactyl. This paper, argued that perhaps, doctors do play a role, but perhaps it's other culprits, infections, things like SBP, septicemia. These are the real most common precipitates of hepatorenal syndrome. So in the same article by Nadim and Garcia Sao, they proposed an algorithm for the management. It's a very busy slide. What I like about this algorithm, it's very clinically oriented. And it helps us in our daily life. I get so mad I write guidelines. There are people in their ivory towers that have no concept of how to take care of a patient in real life. Community hospital, in a non-academic setting. So this algorithm is very, very hands-on. What it argues, again, hepatorenal syndrome is a diagnosis of exclusion. And people have persistent worsening AKI. And they don't respond to volume. And they argue here that people who are dehydrated, easy to diagnose, give them fluid. If they don't look dehydrated, give them albumin. Now, a challenge for us in hepatology, in renal, is being able to diagnose intervolume status. It's impossible. And you hear from different experts, check their jugular venous distension, check the size of portal vein on ultrasound, look at just X-ray for fluid overload. That's great in advanced cases. But we don't have a good measure of intravascular volume. People talk about point-of-care ultrasounds, but we need more help. And in patients who don't respond to albumin, and the creatinine rises, and the urine output decreases, that's what we call hepatorenal syndrome. So this is, again, from the article by ASOD, highlighting that we have a number of options. Vasoconstrictors, Terlipressin, norepinephrine. Norepinephrine is a problem. Someone's got to go to the ICU, then you have central line, and it's got some major side effects. Minorin, nitriatide. We've been using this for many years, with kind of average data. We know it was very safe, not highly effective, but not harmful. So this is a paper published in Hepatology a number of years ago. When you compare continuous use of terlipressin, efficacy was way ahead of minorin-nitriatide. Continuous. So terlipressin has been in Europe for many, many years. Florence Wong and her colleagues published this paper in New England Medicine. Terlipressin has had many rebirths. We were involved with UCLA in one of the original studies 10, 12 years ago. And it didn't meet their endpoint. It wasn't approved by the FDA. So it came back. And in this study where people randomized 2-to-1 with boluses of terlipressin versus placebo. Both groups got albumin. And their goal was reversal of hepatorenal syndrome. And at this time, by the FDA, according to the FDA, they want to see a creatinine of at least less than 1.5. And they have secondary endpoints too. The need for dialysis, getting to liver transplantation and serum creatinine. And the overall result they found was that the use of terlipressin was very effective in reversing hepatorenal syndrome. 32% versus 17%. Very effective. But it came at a cost. It was highlighted by Dr. Bajaj. It came at a cost of side effects. Now, this is a comparison of people in the Terlipressin group and the placebo group. And you see here some things really stand out. And that is shortness of breath and respiratory failure. Compared to placebo, there were about 5 times. So we don't want to rush with Terlipressin. We want to make sure that we understand the benefits and risk. And one of the benefits of the FDA is it combs through all the data. You know, and the data is very much more transparent when the FDA gets a hold of it. And we can look for side effects that may not have been apparent. So they identified a number of risk. These individuals should not be getting Terlipressin. And we're going to go through these categories one by one. So people who should not be getting Terlipressin is people who have a serum creatinine of at least 5. But they're unlikely to benefit. We're just spinning our wheels. And this is an argument for early diagnosis of AKI. Don't wait to get a creatinine of 4.5 to make a diagnosis. Like everything else in healthcare, to earlier intervene, the better outcomes. We're going to talk about ACOF grades. And we're from Dr. Bajaj how this is a very important predictor of outcomes. The fluid overload status makes a big difference as well. And also, according to the FDA, if someone's got a pulse ox of less than 90%, they're going to be at risk of respiratory failure, and they should not be receiving Terlipressin. So this is a paper that was published this year by Michael Curry, using data from the trial from Florence Wong. And what he found here very nicely, there's a stepwise decrease in response the longer way to treat someone. Stepwise decrease of response, the higher serum creatinine. And you see when you have creatinine of at least 5, your response rate is 10% or less. Is it worth the side effects? No. We have to be selective. And you see here also that their overall survival is also related to a serum creatinine level in people who respond to Terlipressin. So early intervention, early diagnosis is critical. And we heard from Dr. Bajaj very nicely about the emerging role of ACOF in our clinical management of patients. And there's all these definitions of ACOF, stage grade 1, grade 2, grade 3. All you need to know is each one presents an organ failure. So ACOF grade 1 means you have 1 organ failure. And there's definitions up here. Grade 2, you have 2 organ failures. And grade 3, you have at least 3 organ failures. So this is from Florence Wong in a separate paper published last year, highlighting that people with grade 3 who are so sick, when the boat's sinking, forget the beach chairs, right? Save yourself. When people's livers are so sick, they're ACOF grade 3, focus on replacing the liver. Forget everything else. These patients with ACOF do horrible with Terlipressin, grade 3. Focus on getting them to a liver transplant center. In Los Angeles, you have, a number of great centers. Cedars-Sinai, USC, and that's UCLA. I bet you right now on the way home, call any hepatologist at these centers, they'll call you back right away. Their job is to hold everybody's hands and get them through this process. It's not clear why we see people getting so sick with the high ACOF score. So one of the theories that's been proposed by Florence Wong is albumin. And like Bajaj says, the albumin has a very specific role in managing people's cirrhosis, prevent SPP. Prevent hepatorenal syndrome, people have SPP. Maybe reduce circulatory collapse. If someone's got repeated paracentesis. And this study here, it shows that, overuse of albumin in these patients who received Terlipressin was actually very dangerous. So perhaps This might be the link why people with ACO grade 3, may develop respiratory failure. Now, as we've heard about other meetings, the face of liver transplant has changed. It used to be we were this meeting years ago talking about hepatitis C cure, talking about how the most common reason for transplant hepatitis C, the most common risk factor for liver cancer with hepatitis C, the most common cause of cirrhosis was hepatitis C. And today we're facing a new devil, alcohol. Alcohol has emerged as the most common reason for liver transplantation. Does anybody know what proportion of people with alcohol hepatitis who need a transplant end up getting accepted for transplantation? 10, 20%, a very small number. 80, 90% of people with alcohol hepatitis are denied liver transplantation, and for a variety of reasons. Lack of social support, lack of insight, or repeated problems with drinking. So 80-90% are not transplant candidates. And so what do? People with alcohol hepatitis, people with hepatitis B reactivation can develop HRS. And so we need to know if we have any therapeutic modalities applied to these patients. This is something we see every day. Whether you're in Lancaster, whether you're in Fresno, whether you're in Carlsbad, you're going to see people with alcohol hepatitis. Our ICU UCLA is full of people with alcohol hepatitis. So how does Terlipressin work in this group, patients who may not be transplant candidates? And in reverse HRS in almost 40% of individuals. So these patients, whether they're transplant cancer or not, should not be denied as long as they meet the criteria of having an ACO of 1 or 2, creatinine less than 5, pulse more than 90%. As long as it meets the criteria. Now, the big question that came up during a lot of meetings before it was FDA approved and afterwards is, what does this mean after transplantation? So the data shows that by correcting HRS in patients waiting for transplantation, it actually benefits them post-liver transplantation in the sense they don't need renal replacement therapy. I mean, could you imagine someone who went through a liver transplant, and you guys know it, in California, your MELD score has got to be 35 plus, which means you're on dialysis, you might be on a ventilator, you're so yellow, you're fluorescent. And then the patient undergoes liver transplantation, and guess what? The kidney was so sick before liver transplant, now they're on dialysis post-liver transplantation. That's horrible. And managing immunosuppression on people on dialysis, it's very difficult. Yesterday, I got a call about a lady of ours who has autoimmune hepatitis, got transplanted on dialysis. With dialysis and fighting her working on our Prograf levels. I know what you're thinking. So if you treat HRS before liver transplantation, what does it mean to your MELD score? And your MELD scores may come down. So the FDA and the company has said, listen, if your MELD score is high enough, over 32, and if it's really high, again, forget the beach chairs. Just focus on getting liver transplantation. So there's been some discussions about how to consider this. And should we be talking about reprioritizing our patient on the transplant list? And the problem is there's so many different guidelines about transplantation. And every couple of years we have a new iteration of a new MELD score. MELD 3.0 coming down the road. The most cost-effective approach to any disease, is prevention. Whether for an infectious disease like polio, measles, whether it be for risk stratification for heart disease, it's prevention. Elliot Tapper and published a nice paper looking at how to prevent, AKI, how to prevent renal injury in our patient with cirrhosis. We take a lot of time about, telling people avoid non-steroidals, and people argue, no, my doctor said avoid Tylenol, not Motrin. Non-steroidals increase the risk of bleeding, and it may also precipitate kidney failure. Avoid ACE inhibitors. If someone's got 10 societies, does it make any sense to jack up the diuretics anymore? No. Effectiveness plateaus out. And, be careful about overzealous use of lactulose. We had a patient, true story, came into a hospital, UCLA, with a sodium of 151, dehydrated from over lactose use. And the debate is the role of beta blockers. How does it affect mean arterial pressures? Bruce Runyon wrote a nice paper in Journal of Medicine, arguing that we should be careful about beta blockers once people decompensate. And management, avoiding nephrotoxic drugs. When people start developing rising creatinine, reduce withdrawal diuretics, early detection of infections, and volume replacement when necessary. So, we're still we're still learning about HRS. We need better biomarkers. We need better serum markers. We need better urinary biomarkers. And there's an active debate now about how we use Terlipressin. There was a great abstract at ASOD and one coming up this week at EASL, showing that continued use of Terlipressin, you have good efficacy with less side effects. Now, in the United States, Terlipressin is approved only as a bolus. So I will keep on using boluses. But later on, we're going to talk about continuous infusion. And, how do we approach ACAS as an outpatient? It's really difficult. You remember the days when we used like Variad or Entecavir, and someone's creatinine went up. Oh my God, I gotta call the patient, tell them to take Variad every other day, repeat blood, and it's a hassle. And so we need a better streamlined approach to ACAS as an outpatient. So with this, I'll conclude that HRS is defined as ACAD doesn't respond to volume. It's a diagnosis of exclusion, much likely diagnose fatty liver. Significant cause of morbidity and mortality, and like most things in healthcare, early recognition and intervention is critical for better outcomes and require aggressive management therapy. So at this point, I want to thank you for your attention. Thank the organizers for having me speak today. And I guess I'll sit down, right, and part of the panel. Thank you, everybody.